Hello, everyone. My name is Dr. Abraham from A&E Dermatology Specialist, and today we are going to take a look at one of the cancers of the skin, the one we call melanoma. And from the pictures that I've displayed, this is how it will present like on your skin. It can be a hyperpigmented plaque on the foot, or it can present with just a skin color change on the sole, or it can even affect your nails like that, or sometimes it can also be on the face. So depending on the location, it may have different names. But all in all, this is a cancer that can affect anyone, anywhere. And oftentimes, depending on the location, you'll be favored to get a particular variant of this tumor. And what you have to understand is that in case you examine yourself and see that you've started to see abnormal different color changes on the skin, you better be assessed by a dermatologist to make sure that you don't have a skin cancer that we call melanoma. As well as people who plait their nails, when you see that your nails have gotten these very dark stripes that are not going away, maybe associated with some little pain, you may need to visit a skin doctor so that they assess you to make sure that you don't have this type of cancer. So melanoma is one of the cancers that originates from the melanocytes. These are the cells that are meant to produce melanin in the body and are responsible for the skin color that we have. So commonly, the skin is affected, but this cancer can as well go on to affect other body parts, including the mucosa, or the cavity, the conjunctiva, the vagina, as well as the uvea of the heart or of the eyes. So these cells can sometimes affect all areas that usually have melanocytes, including the eye, including the meninges. So when you look at the global trends and then the public health impact, you'll find that over the past 4 decades, the cases have significantly actually increased for this particular type of cancer. And this is the cutting across the globe. And you find that commonly in the youth, the prevalence of these cancers is also actually increasing. And this presents a very big public health concern due to the impact of on the quality of life, because we know that melanoma, when it becomes malignant and spreads and metastasizes the rest of the body, it becomes very hard to treat, and you can actually end up losing the patient because it has a very, very high mortality rate. So when you look at the trends, it is significant to note that there's a significant rise in the cutaneous melanoma over the last few decades, and primarily it affects the Caucasian population with lower rates in the dark-skinned individuals, that is the Africans, the Hispanics, as well as the Asians who have a little bit of a dark skin type. The prevalence is a little bit lower, and the global trends have been increasing in the last couple of years, in the way between 3 to 7%, and almost doubling in the last 20 years. For example, if you look at City Connecticut, the prevalence of melanoma has increased by 17 times from 1950 to 2017, that is in men, and 9 times in females. So that means that maybe we are detecting them more, maybe what, but the prevalence is actually increasing. Maybe even the lifestyle has also contributed in one way or the other. So when we look at the global distribution, the highest prevalence of this type of cancer is found mostly in Australia and New Zealand, where you have cases, almost 60 cases per 100,000 people. So that is actually a very high prevalence. When you go to Europe, the highest incidence is seen in Scandinavia and the lower Mediterranean region, reflecting that someone who's a phototype or phenotype of the skin contributes a great deal to their risk of developing the melanomas. When you look at mortality and prognosis, the mortality peaked in the 1990s, and now it has stabilized or a little bit decreasing in adults. And the mortality has a very strong association with the tumor level of thickness, the one we call the breathable depth. And this is a major prognostic factor, depending on the type of diagnosis, how thick is the melanoma. If it is more than 1 millimeter in thickness, that is associated with a poor prognosis. as compared to someone who has it being less than 1 millimeter. Those ones can actually even be cured. So you find that thinner tumors are detected earlier, especially in Germany, where the median thickness has dropped since the 1960s. And this is just attributed to the increase in knowledge, increase in the witch hunting of the precursor lesion, and maybe increased awareness and have health facilities. So you find that in our setting where health-seeking behaviors are a little bit low, and these are usually tumors that can develop over a long period of time. So you find that by the time they present at the clinic, they may have the end stage type, or the one that has actually progressed to beyond repair. So the age being a factor, we need to actually start examining all people aging. You look at their skin, you examine the palms and soles, you examine the nails, and individually you have to also do that as well. So when you look at the risk factors for developing this tumor, we find that this can be grouped into genetic, environmental, and then someone is phenotypic expression of the gene versus the environmental interaction. So in the genetic factors, we have things like the family history of cutaneous melanoma, put someone at risk of developing this type of cancer. You being likely pigmented, so people with a lower Fitzpatrick skin type, that is 1, 2 to 3, they are lighter, so they have a higher risk of getting this type of cancer. And if someone has a tendency to burn and inability to tan, that still applies to the lower skin types, that is 1, 2, 3. And then if someone has red hair, is one of the risk factor for it to develop melanoma. And as well as if someone has a genetic repair defect, so patients living with xeroderma pigmentosa, in that case, they don't have the ability to repair their DNA after the sun has damaged it. So they also have a risk of developing this type of tumors. Then environmental factors, the first one rotates around the sun. If someone gets this intense intermittent sun exposure, they have a risk of developing the melanoma. If someone gets chronic sun exposure, so that one's occur staying in the tropical belt, high significant sun exposure chronically risks you of getting melanoma. Then also residing in equatorial latitudes, even PUVA, that is soldering together with the UVA, there is also a possibility of you getting melanoma, and the use of this tanning bed. So usually this is used by people who are a little bit lighter and they want to actually tan a little bit, and then they want a slightly dark skin type. So the tanning beds also risks you to getting damage to your cells that can give rise to melanoma. Then acquired or iatrogenic immune suppression, like things like HIV, diabetes mellitus, cancer chemotherapy, and the rest, which lower your immunity, meaning that your surveillance against tumor development in your body also puts you at a risk of getting melanoma. Then we have other things like the melanocytic nevi and solar lentigen. All these, when you see them on your body, there's a risk of you developing a cancer eventually. And then if you think maybe having like a typical melanocytic nevi, the dystrophic nevi and the rest, and all these other precancerous lesions can also give you a risk of getting melanoma. So when you look at the cancer development and genetic alterations, the tumor progression in melanoma is basically driven by genetic instability and then selecting for cells that are defective and beneficial with beneficial mutation. So in this case, you have a pool of cells exposed maybe to radiation, then you damage their DNA, then some cells get mutations that are favorable, so these cells will thrive. And these cells in particular, you are looking at melanocytes that are supposed to provide melanin. So the factors that contribute to development of this melanoma include genetic predisposition, environmental triggers like ultraviolet radiation, and then the host immune response. And we know very well that the hallmarks of cancer, we know the 8 hallmarks of cancer, if the cancer cells are able to evade apoptosis, meaning that they attain immortality, they evade the immune response, so they can't be detected and killed by the immune system. meaning they have removed all the markers that your immune system can recognize, they can end up being malignant. And then the self-sufficiency signals in growth, meaning that themselves can stimulate their own growth without needing your external input or your body's input. Then the unlimited replicative potential and sustained angiogenesis and metastasis. Metastasis meaning that the cells can move now from the area where they were at first and go and invade another area and actually implant successfully. So all those factors contribute to the development of melanoma. So the key mutations or pathways that are affected in melanoma include the following. The very first one is the MAPK pathway, and in this pathway, there's usually a mutation in the BRAF and the NRAS genes. And these, you know that these ones are very key as they play a role in signal transduction. And at the end of it all, they promote cell proliferation and growth. So if they're defective, meaning that their promotion is not checked, so the cells can promote immortality. Then the second pathway that is usually affected is the P13K pathway. And in this case, there's usually a mutation in the KIT gene. And the other pathways that have been also implicated in development of melanoma, we have the cyclin-dependent kinase N2A pathway, as well as the TP53 gene, that we know that this is a tumor suppressor gene. So a mutation in this gene also has a big impact in the development of melanoma. So when you look at the impact of ultraviolet radiation or exposure, so when someone gets intermittent or chronic sun exposure, there's an association with this sun exposure causes high mutations in the BRAF gene. So in this case, someone ends up getting mutation in the melanocyte, affecting this particular line of signal transduction, which is within the MAPK pathway. Then, if someone still gets the chronic sun exposure, the mutation burden is also high, and also UV light signature mutations are usually seen. That includes the NRAS, the TP53, the cyclin-dependent kinase N2A. So all of them can be mutated, or they can get a mutation which is triggered by sun exposure, either chronic or intense intermittent sun exposure. So all these molecular targets that we have looked at, they are very key because they can be target for therapies, knowing that if the mutation is here, if you can target and block it, then you're able to treat the cancer. So in this particular diagram, we try to show you the location of each particular pathway. For example, if you see the BRAF protein is located here, the NRAS is here, and these are very important in the signal transduction from the cell receptor, usually maybe the tyrosine kinase receptor, getting information from outside, that is maybe like the KIT gene. So if it is mutated here, meaning that even signal will be transacted down without necessarily actually needing a signal from your body or a growth signal. Then if BRAF is mutated or if NRAS is mutated, meaning that this downward pathway, usually they gain what we call gain of function mutation, meaning that they are overstimulated. So at the end of it all, you'll have stimulation of the cyclin-dependent kinases, which will now cause phosphorylation of the subsequent proteins, resulting into freeing of the retinoblastoma gene from the E2F, and E2F usually goes to the gene and then triggers or promotes cell growth and proliferation. So if someone has self-sustaining or still has self-sustaining and self-stimulating pathway, meaning that you don't need your external growth signal for you to activate this pathway. So this cell becomes autonomous and immortal. Then other genes that can also be mutated, we talked about the P13K pathway. In that case, where you can either have mutation in the P10 gene, or you can also have a mutation in the ATK gene, or you can also have mutation in the PDK1. So any mutation in this area still will activate the growth signals through the mTOR pathway, and in this case, you still end up having cell growth and proliferation being promoted by these particular mutations that someone has acquired. And when you look at the MAPK pathway, or what the mutagen activated protein kinase pathway, it plays a key role in cell proliferation, growth, and migration. So in case of any of the pathway or any of the proteins within that pathway, if they are activated, The net effect is cell proliferation, growth, and migration. So most of the receptor proteins that are activated include the KIT protein or the KIT protein, which is a growth factor receptor. If it is mutated, most of the time they can even send information without necessarily actually needing a cell survival signal, or it becomes too much responsive to any slight information that has a positive growth signal from the body. So meaning that you have downward transduction of information that stimulates growth, proliferation, and migration. So other signal transduction involves the NRAS, the BRAF, the MEK, the hierarchy, and all these can be mutated. But in melanoma, most of the mutations can involve the BRAF mutations, that is up to 60% of them, and then the NRAS mutations that contributes to about 20%, as well as the KIT mutation. So in melanoma, when it comes to the MAPK pathway or the mutagen activated protein kinase pathway, we usually have either the BRAF mutation, you have the NRAS mutation, or you have the KIT mutation. Three of them in this pathway can be mutated. So when you go to the second pathway, the P13K, which is the phosphoinositidine 3 kinase pathway, in this case, this pathway also plays a key role in survival, growth, and metabolism. So in tumors, they usually also the cells are usually they have a very high metabolic rate compared to the normal cells. So these cells, if they are mutated in this pathway, meaning that their metabolism will be higher than the normal cells, and they will utilize a lot of proteins, a lot of glucose, and a lot of nutrients from blood that drive the growth of the tumors. So in this pathway, we have receptors like the receptor tyrosine kinase, and when you activate it, you usually this one leads to the ATK phosphorylation, and then AKT will cause activation and promote survival and growth via the mTOR. And it also inhibits apoptosis, that is now cell death, meaning that if you have a mutation in this pathway, you are one inhibiting the apoptosis, but at the same time you're promoting cell survival and growth via the mTOR. And this one can occur if you have a mutation in the ATK, if you have a mutation in the RTK, that is the receptor tyrosine kinases, and any mutation in this pathway can give you that as an outcome. But now in melanoma, we usually have a loss of function mutation, the P10, and P10 is supposed to now block this pathway and inhibit it. So if you have a loss of function mutation in the P10, meaning that this pathway will go unchecked. And then you find that in some of the melanoma cells, they have overexpression of the ATK, that is now the protein that will be now overexpressed. And remember, this one comes with a positive signal for survival, growth, and metabolism. And then occasionally, they can also have a mutation in the NRAS, as we've seen earlier. So in this pathway, the melanomas can have a loss of function mutation in the P10, overexpression of the ATK, and then the NRAS mutation. So the next pathway is the Wnt signaling pathway, and Wnt signaling pathway is very key in embryogenesis of the skin and migration of cells, especially the melanocytes, as well as the growth of the hair follicles. So you'll find that, and you know that even at the base of the hair follicle, we have melanocytes. So you'll find that this pathway can also, the net effect of this pathway is to regulate cell differentiation, migration, and proliferation. As we've seen in other embryological processes, the Wnt pathway does the same function. So in this mechanism, usually the Wnt pathway will stabilize for you the beta catenins, and this will promote for you growth and migration. So it can act as either a promoter for tumor growth or sometimes even a tumor suppressor, depending on this pathway, how it is regulated. So you'll find that in melanomas, we usually get stabilizing mutation in the beta catenin that are a little bit rare, but they increase intracellular beta catenin that has been observed in melanoma. And because of the net effect is a promoter effect that promotes for you that is growth, differentiation, migration, that the net effect in this case in melanoma. So we usually get in this pathway for melanoma, we can get stabilizing mutation in the beta catenin. So the last pathway is the MC1R or the MITF signaling pathway. This one also plays a role in regulation of pigmentation, skin color, and also hair of the color of your hair. So when it is activated, it can also be acted upon by melanocortin, that is a hormone that usually comes from the brain. It usually stimulates cyclic AMP that later on activates the PKT, and then the CREB. This leads to MITF expression. So the major role is usually uh, um, it regulates the melanocyte-specific genes, including the cyclin-dependent kinase 2 and then the BCL2. So these key enzymes are also very important when you are either inducing apoptosis, in case a cell is damaged, especially the BCL2 gene-derived protein. They usually respond in case a cell is damaged. When they're expressed in large numbers, they usually trigger destruction of that particular cell. But then, in this case, if they are modified, if you have a loss of function mutation, meaning that these cells can now not be destroyed, and in that case, they will act as an oncogene in melanoma, but can also induce cell cycle arrest. You know, that is usually the normal thing that they do, especially the BCL2. So when meat is expressed, it's also modulated by the MAPK pathway and the Wnt pathway. So in case it is now overexpressed, but at the same time you don't have the function of the MAPK and the Wnt pathway, it means that you end up driving towards development of melanoma. So these are the different gene mutations that have been identified in the different types of melanomas, as we are going to see. And you'll find that when you look at the melanomas where you have little or no chronic sun exposure or damage, you will find that most of those will have mutations in the BRAF gene as well as the NRAS. Then others that will have chronic exposure to sunlight, you'll have mutations including the BRAF, including the NRAF. Then you can have the KIT and NRAS mutations as well as the KIT mutations. So that is also for acro. Acro will have almost similar, but in this case, it will have KIT and BRAF mutation. And in mucosal, most of the time, it has KIT and NRAS mutations in case you get a melanoma in the mucosal area. So you'll find that this is a polygenic type of mutation that gives rise to different types of melanoma, and each melanoma, you find it has its particular line of the defects in the genetic makeup of the deformed cells. So when you look at melanoma and how your body responds to it, so clinically we can have clinical signs like tumor regression and vitiligo-like depigmentation that you usually see in the melanocytic lesions, and this one we think that it is indicative that your immune response at some degree responds to try and destroy the deformed cells. And you find that melanoma antigens can be identified in the body, and this one can include the mutant antigens, especially the mutant antigen P16. You can get cancer testing antigens like the MEG1 and NYESO1, and then also you can get diffusion antigens like the tyrosinase and then the MAT1. So all these antigens, since you are able to pick them in blood, it means that even your immune system tries to scavenge and kill these deformed cells, but it just overwhelmed, and then maybe some of them, they don't express those antigens that your immune system is able to identify and destroy. Remember, all cells in the body express almost MHS class 1, that is immunohistocompatibility class 1, that is usually expressed in case that cell is defective, that cell is infected, or that cell needs to be destroyed. So these melanocytic cells that are deformed usually don't express that MHSA class 1, meaning that your immune system cannot respond to destroy those cells. And then the key immune mechanism that we usually employ is the CD8, and these are cytotoxic cells that are supposed to recognize MHS class 1 peptides and destroy the tumor cells. And sometimes you can also employ the CD4 cells that produce antibodies against these particular mutated cells in the body. And we have immune checkpoints or escape mechanism for the melanoma cells. You find that we have checkpoints in the pathways like the CTLA4 and PD1 and STOC PDL1 pathways. This is supposed to actually inhibit T-cell activation and also allow melanomas to evade the immune system. So as these melanoma cells get this mutation and express these particular proteins and pathways, they are able to evade your T-cell activated immune response. So the other thing that I mentioned earlier is that the melanocytic cells that are deformed will tend to lose the MHS class 1, meaning that your CD8 cells cannot actually come and destroy them. The other thing is that these other checkpoints that are supposed to actually inhibit cell growth, for example, the tumor suppressor gene, the TP53 is turned off, the mTOR is activated, which will give just on a positive signal. So you find the combination of all these give rise to development of this melanoma. And in advanced immunotherapy, you find that you can actually target these particular defects or cells to do what? To eradicate or to deal with the melanoma, as we are going to see when it comes to treatment. So melanoma as a skin cancer can have different clinical presentations or manifestations, and these are what we call variants in dermatology. The first and the most commonest variant is what we call the superficial spreading melanoma. So the superficial spreading melanoma is the commonest and it contributes up to 70% of all melanomas, and frequently it is diagnosed between the ages of 40 to 60 years of age. And typically it appears on the trunk in men, and when it comes to women, most of the lesions are located on the legs. And it will begin as a symptomatic brown to black macules with different colors, irregular shapes, irregular shaped or notched borders, and it can rise de novo, it can occur in a pre-existing nevus, especially if it is a dysplastic nevus. So initially it will grow horizontally. That is why it is called superficial spreading. But as it progresses, as it advances, it can also take on a vertical growth in case you have not attended to it in the due time. And as it progresses, it will turn gray a little bit, have depigmented areas which show immune response. And this can be observed up to 2/3 of the tumors, indicating immune response. So around 50% of them, they can arise from the existing nevi. So that's why even when someone has this so-called birthmark hyperpigmented nevi, you need to actually take pictures and then monitor them, because they can actually end up being superficial spreading melanomas. Then, as you can see in this picture, let me first show you how it will look like. So you see this. This is how the superficial spreading melanoma will look like. These areas having now here the depigmentation, there's a scale, there's hyperpigmentation, brownish, gray. So, and even the borders are not a little bit clear. So that is all, that's how a superficial spreading melanoma will look like. Then the next form is what we call the nodular melanoma. In this case, it will appear like a nodule, and it's the second commonest type of skin or cutaneous melanoma in individuals who have a little bit of a fair skin of Fitzpatrick type 1 to up to around 3. So commonly it will account for up to 30% of all melanomas, 15 to 30%, and most frequently diagnosed within the 6th decade of life, around 60 years and above, commonly seen in men compared to men. Lesions are commonly they can found on the body side, but most of them are seen on the trunk, head, and neck. Presentation, someone will have this blue to black or sometimes pink to red nodule that oftentimes can be either ulcerated with bleeding, sometimes associated with a rapid growth over a very short period of time. And this type of variant is very rare in children. Oftentimes, it can also be a melanocytic, especially if it occurs in pre-pubertal patients. So in that case, it will appear as a whitish nodule or even skin colored, without it necessarily being black or blue, as we can see in the picture. So as you can see from the word, it is nodular melanoma. So the primary in that case will be a nodule, or it will be a nodular plaque. So in this case, you'll find that it has even a deeper component. So this is a type of melanoma that has a vertical growth, meaning that it goes into the skin. So through the dermis, through the subcutaneous layer, it can reach as far as the bone. So as you're going to see in a few seconds. So the other type of melanoma, uh, uh, so this type of melanoma, as you said, it usually has a growth pattern, which can be de novo sometimes, but it grows vertically. So, and that's how it will appear like. And when you look at incidence, its incidence has remained a little bit stable over the recent decades, unlike for the superficial spreading and then the acrolentigенous melanoma, whose prevalence has started to increase over the last 4 decades. So when you look at another type of melanoma, the one we call the lentigo malignant melanoma, in this case, it will look like the solar lentigen at first, but then later on, you see that now you find that the skin color has started to be, it will change. Some patches looking blacker, others brownish, others hypopigmented, others hyperpigmented. And this type of melanoma accounts for only about 10% of the cutaneous melanoma, frequently diagnosed in the 7th decade of life. And it is considered to occur in young individuals who have had a significant cumulative sun exposure, especially people living in the tropics that usually receive sun over the 356 days of the year. So the common location of the lentigo malignant melanoma, oftentimes it will come in areas that are chronically sun damaged. So oftentimes it will occur on the face, and it also lasts the tip of the nose around here as well as around the cheeks. So it will appear as a slowly growing asymmetrical brown to black macule with color variation, irregular borders, and then these borders can as well be indented. So as you can see in this picture, so this is how it will look like. You see that the border is not clear. You can't draw either circle, a rectangle, a triangle. So the border is irregular. But even within the region, you see different colors. For example, where you are seeing this yellow that I marked out here, this is now hyperpigmented. But now, even if you draw this circle, the circle will have more than one color. So it will have a polychromic type of appearance. And you see the diameter of the entire region. I marked out this red circle. You see it is more than even 6 centimeters in diameter. So that is how lentigo malignant melanoma will look like on the face. And in terms of progression, it's analyzed from a precursor lesion called lentigo malignant or melanoma in situ, especially in sun-damaged areas. And approximately 5% of lentigo malignant lesions can progress to invasive melanoma. So when you see lentigens or lentigo malignant lesion, you need to actually follow them up and keep taking off biopsy to make sure that this individual has not gotten the overt melanoma. And when you do dermoscopy on these lesions, you'll be able to see hyperpigmented follicular opening, which we usually call a circle in a circle pattern. And in that case, you as well see irregular pigmented dots around the hair follicles, which you also call the annular granular pattern. Or sometimes you can see rhomboidal structures. They can also be present on dermoscopy. So when you look at any lesions on the skin, if it is on the face, someone is about 6 years of age, they're getting this particular hyperpigmented lesion, irregular shape in an dermoscopy, you see these features have in a circle pattern or annular granular pattern or rhomboidal structures. You can now start thinking about melanoma. But even the shape of the lesion clinically will give you a clue. As we can see here, I've already explained those pictures. So the other type of melanoma is what we call the acrolentigenous melanoma. And just from the word, you have the idea of where this melanoma is occurring. Acro usually means the foot or the palms, and lentiginous, that means it looks like just like the one we've seen before, and it is also a type of melanoma. And this one is a little bit rare, accounting for only 5% of all the melanomas. So this is commonly diagnosed in the 7th decade of life. I think I remember one of the patients that I have currently, we are investigating for melanoma, she's 78 years old. So It has a disproportionate prevalence in dark-skinned individuals. This is the cancer that usually get as black or African, the black African people. And we will find that this type of melanoma in our setting, it contributes to 70% of all melanomas that we get, as opposed to the whites. The whites now, their most common type is the superficial spreading type, followed by, so for them it is superficial spreading type, followed by the nodular type of melanoma, and then followed by the lentigo maligna melanoma. But in our case, the commonest type is acroantigenous melanoma, which accounts for almost 70% of all the cases that we see. And you find that when you go to the Asian population, the acroantigenous melanoma accounts for 75% of all the melanomas they get. And you find that this can be explained, that you find that for the African Americans, our skin usually has a lot of melanin, which is a little bit protective against the development of this cancer, because the melanin is protective against sun damage. So the only area that we have little melanin is actually the sole and the palms, which usually has a little concentration of melanin. So that could explain why we usually get chondrogenous melanoma more than the other forms of melanoma. Then when you look at its location, common area with palms and soles, as I've mentioned, but sometimes you can also have it appearing around the nail apparatus. And it will appear as a asymmetric bound black macule with a color variation and irregular borders. As you can see in this picture I put for here at the corner, so this is how it will look like. You see this color variation, the irregular borders, and this plaque that you see here on the heel of this patient. So this type of melanoma presents a little bit of a diagnostic challenge, and oftentimes it is seen in the end stage, because since we are we are dark naturally, you'll find that most people actually see the skin color change, but they don't mind. It's not painful, just maybe expanding. They don't even pay keen attention, and you find that most of the times they bathe in darkness, so they can't see the melanoma. So by the time they see it, it is already symptomatic. It has started to cause pain with ulceration, bleeding, and what, and then it is usually a little bit late. So you'll find that most common cases are diagnosed when they're late, that is in advanced stage. And it may be hard for you to distinguish it from other benign lesions caused by trauma. So if someone can think maybe I was pricked by a nail, by a thorn, and I was digging, I have a splinter, so something like that, which basically will delay the diagnosis. So sometimes you can also get other types of melanoma, like the nail matrix melanoma, and in that case, it can present as longitudinal melanonychia, or with the Hudson sign, that is usually pigmentation which goes beyond the nail fold. So you get a pigmentation, you can get a normal melanonychia. I don't know if you can see this. Usually melanonychia, because I also have it here, it's like what you call a birthmark, but in this case occurring in the nail. That's the normal melanonychia. But now you'll find that patients with melanonychia involving, melanoma involving the nail fold, they will get this black pigmentation that goes beyond the nail fold. So it will be even up here at the nail bed, just below here where I'm pointing, and it can go even beyond where the nail stops to affect the subungual areas, or even it go ahead and affect the pulp, the end of the finger. So when you see such a thing, that's what we call the Hutchinson sign, where you're having the pigmentation going beyond the nail fold, and that is usually suspicious for nail matrix melanoma. So suspicion should be raised in case someone has a fair-skinned individual with dark, irregular, and or even wide pigmented nail bands, which are more than 3 millimeter in diameter, as we saw in the very first picture that I showed on the screen. So it has genetic characteristic. Usually it can be distinct from other types of melanoma. Oftentimes its mutation is usually a KIT activating mutation, and we know that KIT is one of the receptors located at the surface of the nucleus membrane. So when you activate this receptor, we say that this receptor is supposed to now cause signal transduction through the MAPK pathway that results into activation of a growth signal by releasing the EF2, E2F, that is a growth promoter, and it calls for transcription of proteins that promote growth of that particular cell. And this type of melanoma is very good. I want to say it's very nice because it usually responds to KIT inhibitors. If you're able to give imatinib, so it will give you a good response. So we have other variants of melanoma that we can also talk about today. The first one is what we call the melanocytic melanoma. So in this case, it will lack the visible pigmentation, and it can be just like any other forms that we've talked about, the superficial spreading, the nodular, the lentigo maligna, or even the acrolentiginous melanoma. It is very hard to diagnose because oftentimes it can be mistaken for either a wart or even a basal cell carcinoma, but the progression is similar to the other forms of melanoma. We can also have a melanoma called the spitzoid melanoma. This exhibits features which are similar to the Spitz nevus. That means that you show the symmetry, the dermal epithelioid melanocytes, even when you take off a biopsy. So it can also be confused with this type of nevus. So, but the difference will be in this case, you'll see the typical melanocyte as well as mitotic figures, which will now make you think that there should be a malignant process going on in this case. And oftentimes, this type of melanoma, you may need to do other things, the immune sustaining, as well as the fish that is the hybridization test, such that you are able to make a diagnosis of this type of melanoma. Then you have what we call the desmoplastic melanoma, or oftentimes this will present as a skin-colored red or brown, black nodule, or even a plaque arising de novo. Sometimes it can be with other types of melanoma, especially the lentiginous melanoma or lentigo maligna melanoma. Oftentimes it is deeply invasive, and it can reoccur even after an incomplete excision. It can occur, and it can be very stubborn when it comes to removing or treating this type of melanoma. Then we can also get the clear cell sarcoma. This typically presents on extremities of adolescents and young adults associated with tendons, and then aponeurosis. So especially where you have the Achilles tendon, and that's where you see it commonly. And it can also be classified as a subset of melanoma with distinctive genes that gene features that include the EWS 80F1 fusion. So this is one of the rare ones, but when it comes, you can think about it. So other things like the malignant blue nevus can also be taken as one of the pigmented skin cancers. And in this case, a bit rare, it presents on the scalp. Someone will have blue-black nodules with a typical melanocytes, mitotic figures, as well as necrosis. And it has a very high rate of recurrence as well as metastasis. So it can usually spread going all the way to the liver, to the lungs, as well as the brain. Then we can also get what we call the ocular melanoma, and this is the very rare, only 5% of all melanomas. It can be divided into two. It can either be conjunctival melanoma or sometimes uveal melanomas. So in this case, depending on the diagnosis, you may need to work with now ophthalmologist, and sometimes if it is only the conjunctiva affected or the uvea, you may actually end up needing to remove the entire eyeball to make sure that this patient does not progress or can't get metastasis to other parts of the body. So prognosis is usually influenced by the chromosomal changes. So if it is the monosomy 3 defect, then we can have a bad prognosis. Then mucosal melanoma, this is a little bit rare, where the melanoma now affects the mucosal areas, especially in the mouth and the anogenital areas. And in this case, oftentimes you can also get a melanocytic type, which can be very hard to diagnose, and oftentimes it is diagnosed when it is in the late stages, when it is advanced melanoma already. So also the genetically it is similar to acrolentiginous melanoma with a potential of KIT mutations. So as you can see in this picture here that I put for you, so this is another type of melanoma affecting the conjunctiva, This is mucous melanoma, pigmented, affecting the mucous membranes, especially in this case, it is affecting the gingiva. So these pictures now try to show you, to sum up the different variants that I've been talking about. So this is the nail matrix melanoma I told you earlier. So a normal person will have what we call melanonychia, which is like a birthmark in the nail, those black pigmentation. But if you see those pigmentation going more than 3 millimeters in diameter, and then going beyond the nail fold, just like you see here. So you have to think about nail matrix melanoma. Now this one, you see the lesion has no clear border. It has hyperpigmented, brown, black, red, white, very many colors. And that is the integral maligna melanoma located on the face. So still, this is what we call the superficial spreading melanoma. Now this is located on the chest. You can see here, this is the nipple. Then this is acral lentiginous melanoma, and then this one is a melanoma in situ. This is just an inset of this lesion that you see here. So you need to monitor these patients, and then you have to make sure you take off the samples, make sure they are not turning malignant. Now this one here is a nodular type of melanoma. So melanoma and pregnancy. So there's a thinking that we have a strong hormonal effect on melanoma, especially during pregnancy, because you know that during pregnancy, you have elevated hormones, growth factors that are supposed to stimulate growth of the baby. And then you know that some of these growth factors or hormones actually end up causing hyperpigmentation, giving you the linear alba that usually see a black line on the trunk of pregnant mothers, darkening of the alveoli of the nipple. Some pregnant mothers actually end up with darkening of the gingiva, and all this is under stimulation of the melanocortin hormone that is produced during pregnancy. So this as well, since it stimulates melanocytes, can as well end up stimulating melanoma development and also worsening them. So if someone is pregnant, they have a pre-existing melanoma, we expect it to actually worsen. But however, the impact on melanoma development is not yet well, how can I say, well elucidated. So, but if someone already has a pre-existing melanoma during pregnancy, we expect it to worsen because the hormones stimulating melanocyte development are more in pregnancy. But if someone has no melanoma, we don't think there will be the hormonal will not cause development of melanoma, and there's no total association. And placental metastasis, they're extremely rare in pregnancy women, and with very few documented cases where maybe someone was pregnant, had melanoma, and then the melanocytic cells ended up causing the placenta to affect the unborn child. So when you look at management of melanoma during pregnancy, psychiatric excision, and then sentinel lymph node biopsy are very key, because you want to now to stage this tumor and see how to manage it. And then non-invasive imaging like ultrasound, MRI, and can be done. But things like the CT scan, X-rays have to be avoided in pregnancy. So these other non-invasive modalities can be done to assess the extent of the cancer and see how to deal with it. So it is advisable, if someone is pregnant, you have to wait about at least 2 years after melanoma diagnosis if you want to become pregnant, and there's a risk of recurrence. Oftentimes, especially if you get pregnant, and then if there's any one cell that was left during the excision, it can actually grow and give you a brand new melanoma. So when it comes to contraception, there's no evidence of hormonal contraception adversely affecting melanoma development, and they can be used actually. So there's another type of melanoma, depending on age, we call it the childhood melanoma, and this is very, very rare, only contributing about 2% of all melanomas. And you'll find that in patients less than 20 years, 2%. But as you go below 14 years, the cases of melanoma drop to less than even 1%. So that is approximately 0.3%. So it means that melanoma in children, very, very rare. So the risk factors are similar to those in adults. with minimal contribution, which is from xeroderma pigmentosa, and also a giant congenital melanocytic nevus can be a risk factor for developing melanoma at an early age. And when it comes to diagnosis, if it is pediatric, we usually use ABCD. In this case, we can use A standing for a melanocytic lesion, B stands for bleeding or a bump, and then C stands for color uniformity, and then D stands for the novel appearance of any diameter. So for children, we don't need to actually look at the diameter, provided a rash has come and it came on an area where there was nothing before, we can call that a score. So in the histological features, which resemble the adult type of melanoma, but sometimes split nevus melanomas are also seen in children and may present a diagnostic challenge. So what do we do if you want to diagnose melanoma? How do we diagnose this skin cancer? So early detection is usually very key in improving survival because it helps you to eliminate this malignant tumor before it metastasizes to distant areas that make treatment a little bit more complex. And you can do this with visual inspection. You can use a dermoscope, and you have to take a clear history of the color of the eruption, the size, the changes over time, and this is usually very, very key in your history taking. Then we use what we call the ABCDs of melanoma. And A stands for asymmetry, as we've seen earlier. Usually the borders are irregular. B stands irregular, so it can be either, instead of being a circle, it can be some form of an elongated rectangle, something. And then B stands for irregular borders, so you find that the borders are not well demarcated. And then C, color variation, the colors in the lesions are different. You can see different colors, or either trichrome, polychrome picture. Then the diameter above 5 millimeters in diameter, and then evolution, which is usually changing in the size of the lesion over time. So when you do dermoscopy, the features can include a pigmented network. We usually get streaks as well as aggregated globules, and then homogeneous blue pigment, and then also parallel pattern, which we've seen in acro lesions. So this is what we are talking about. So if a lesion is symmetrical, it will be like uniform, like round, as you can see here. So that is now usually benign. So this is round. But when you come to a melanoma, you see the borders, you cannot actually clearly mark them out. Then, and when it comes to borders, in this case, if it is benign, the borders are very, very even. You know where the lesion stops. But in melanoma, the borders are very uneven, as you can see in this lesion here. When it comes to color, this one has one color. And then in melanoma, we are having very many color with hypopigmentation at the center, or even depigmentation. 2 or more colors will now suffice for you to say these are various colors. So benign, usually small, 6 millimeters in diameter, half an inch, but here more than 1 millimeter in diameter, so that is big. Then if it is ordinary mole, it usually evolution is it remains the same size almost a very long period of time. But if it is melanoma, it will change in size, shape, color, and other traits over time. So that is how you diagnose melanoma using the ABCDs of melanoma. So when it comes to dermoscopy, these are the things that we've been talking about. You see these streaks, you see these pigmented globules, and sometimes you see even blood vessels. So all this, and then the different colors that we usually see on dermoscopy. And you see the asymmetry still even on dermoscopy, you can actually pick it. So when it comes to the histological features in melanoma, you find that taking off a biopsy is the gold standard if you're making a diagnosis of melanoma. And in that, you do staining with H&E, and also as well with the special stain and immunohistochemistry. And there you'll have your diagnosis of melanoma. So in the growth phase, remember I told you earlier that we have 2 particular growth phases. We have the radial growth and then the vertical growth. The radial is like superficial or horizontal spread. And in that case, usually there's no metastatic potential. But every time there's vertical growth, there's usually high potential for the deformed cells to go into blood vessels, and then they will end up being transported to other areas of the body. So remember, some melanomas can start as superficial spreading, but long-standing ones can, after finishing vertical horizontal growth, they now start on vertical growth. So you have to be keen. So in histological features, you usually see asymmetry, you can see nests of melanocytes, not equidistant, varying size and shapes. You see intraepidermal tumor cells, usually you can see solitary melanocytes can predominate. Sometimes they can extend into the confined layer, and in that case, sometimes you call it the melanoma in situ. And then you can also have dermal invasion, where you have melanocytes going into the dermis, and this one are usually of different sizes, and you can also see other features of atypia, mitotic figures, as well as cell atypia. And then you can see features like if it's nodular melanoma, you usually see vertical dermal extension into the epidermis and the dermis as well. If it is lentigo malignant melanoma, usually this one can spread in seen in sun exposed areas, and it can have spindle cells as well as desmoplastic changes. And then if it is acroantigenous melanoma, it can also spread with typical melanocytes in the basal cell layer as well as the upper epidermis. And when you do microstaging now you're looking at the vertical penetration, how much is it? And then that's when you use the breakthrough depth, and this is one of the most important indicators for survival. So if someone has a good score here, meaning a smaller value of vertical spread, they have higher chances of survival. If it is big, lower chances of survival. And if the tumor is ulcerated, it means that poor survival. If it is not ulcerated, better survival. And when you do immunohistochemistry or immunohistopathology, you can use other markers like HMB45, S100, and then the SOX10. This can help you distinguish melanoma from other tumors, but they are not definitive on their own. So after doing H&E staining, you can now do the special stains where you do HMB 45 or the S100 or the SOX stain, and it will help you to distinguish it from other differences that you may be having. Then you can also do the MITF and then SOX10. This is useful in diagnosing the desmoplastic melanoma and differentiating it from other things like solar lentigo and also the lentigo maligna. So this is now the breathless thickness. As I told you earlier, we will now examine the distance of the last cell that is infiltrating the skin, and then you measure this distance from the epidermis all the way down to where that level is, and that is usually very key in determining the survival. So if it is in situ, meaning that it has not yet gone below the epidermal junction, which is on or above, the survival rate is about 90 to 100%. But if it is less than, so that is in stage 1, if it's less than 1 millimeter, the survival rate can go up to 90%. If it is between 1 millimeter to 2 millimeters, then the survival rate starts to drop to 70 to 80%. That is within the 5 years. If it is 2.1 millimeter to 4 millimeters, so the survival rate goes to below 70% under 5 years. And if it is above 4 millimeters in diameter, in depth, the survival rate goes below 50%, meaning that your breath loss thickness or the depth will be very key in determining the survival of a patient with a malignant melanoma or melanoma. So this is how the histology will look like. In this case, this is how melanoma will look like. You see these melanocytes within the pigment, all the way having nest all the way down, and this is how they're looking like. You see now here, they are they are going as high as the what? The stratum corneum. And you see when there's a pigment there. So this is how melanoma will look like. Now you see the cells have now infiltrated, going all the way through the dermis, and they're all going down to the dermis and as well as the subcutaneous layer. And still, this is another type of melanoma. This is how it will look like. And then you see these are typical cells as well. And then this one is lentigo maligna melanoma. And this is how it will look like. You see these are typical cells, all these forming these nests, all these nests are nests of abnormal melanocytes. All those cells, all those cells. Okay. So still this one, still similar to the other one, all these cells, these are abnormal melanocytes are eating up the skin. So when you go to molecular analysis in melanoma, there are different particular advances in technology that can be used, including the comparative genomic hybridization. This one will check the DNA copies. If you're looking for the number of changes, gain or loss of function mutations in melanomas, and but you cannot use it in benign nevi. And then you can also use fluorescence in situ hybridization. This one can help you identify chromosomal changes and see if there's any defect somewhere. And you can also use gene expression profiling. These are a little bit advanced, and this one helps you to classify whether someone is in low risk or high risk category of developing melanoma. And then you can also use next generation sequencing. This one helps you to analyze different genes to target different therapeutic in different therapeutics, which can be used in particular patients. So this is the future of medicine, where we shall one time reach an era whereby we just do your genetic testing and they know your genes and look for targeted therapies that can actually cure you of particular disease. Then still in melanoma, we have what we call the Clark's levels. And then these Clark's levels are very key to tell you the level of invasion of melanoma. So in level 1, it implies that the melanoma has invaded or has remained confined to the epidermis without going to other layers of the skin. Then in level 2, it has now gone down to involve the papillary dermis. And in 3, it has now reached the reticular dermis. When you go to 4, it has now invaded up to the subcutaneous tissue. And if it goes beyond this, to involve either the muscle, the fascia, as well as the tendons and bones, that is now level 5. And by that time, even survival rate is less than 50% for the 5 years. So this is how the Clark's levels are looked at. So this is level 1, then 2, 3, 4, 5. So we can also use the TNM staging for melanoma. And in this case, this may be very hard for you to cram, but this is a table that you have to know that it exists. So that every time you have a patient of melanoma, you can reference to it. So in this case, the TNM, the T usually stands for the tumor. And here you categorize the tumor depending on the thickness versus the presence or absence of ulceration. So if the tumor is there with ulceration, then you know what is the thickness, what is the size, and then different sizes give you a particular category. For example, if the tumor is more than 4 centimeters more than 4 centimeters in diameter, then that puts it at T4. 4 at 4, and then 3 is usually 2 to 4, and then 2 is 1 to 2 millimeters, and then 1 is usually less than 1 millimeter in thickness. So then the other category is A is usually without ulceration, and then B is with ulceration. Then sometimes they add on 0 if it is unspecific, and you cannot add classify it very well. Then the N usually stands for the lymph nodes that are involved. So in this case, we categorize them either depending on the number of lymph nodes involved, either regional or distant or sentinel, and usually together with the presence of in-transit or microsatellite melanomas within the lymph node. So if you take off a sample, then you see melanocytes within the lymph node, then you have to score it. If there is no, then you also score it dependingly. So then the last one, in the last category is the M which looks at the metastasis. And in this case, you have to look at the anatomical site and then the lactic dehydrogenase levels, LDH levels, and these are assessed together. So it is M0 if someone has no evidence of distant metastasis, and it goes to 1 if there is evidence of distant metastasis, And M1A, if someone has different metastasis to skin, soft tissue, including muscle, and then with or without regional lymph node involvement. So in that case, you have to also assess the LDH levels. So if it is elevated, then that one puts the category M1A, that is 1, A1. So that is how you base to classify this melanoma using the TNM system. So remember the difference with other tumors. Here we have to use the anatomical site together with LDH. Then when it comes to tumor, we use the lymph node together with presence or absence of laceration. So when this staging helps us to determine how someone will survive, the survival rate. So if someone has xeroderma melanoma in situ, usually it's confined to the epidermis and there's no invasion into the dermis, survival rate can be 100%. At the diagnosis, treated, cured. Then if it is stage 1 and it is localized, it is just localized disease, and in this case, survival rate starts to drop. If it is stage 2, localized disease with high risk, survival rate goes down. Then in stage 3, it is regional metastasis, survival rate goes further down. And then in stage 5, or sorry, 4, you have distant metastasis and survival rate is very low. So this graph I put for you here in the corner tries to show you the different survival rate depending on the stage of someone. So you find that if you are to do 5-year survival rate here, someone who is at stage 4 survival rate is less than 20%. Someone who is at stage 3, maybe 60. Then stage 2, maybe 70, and stage 1, maybe 90. So that is what simply it means. And still, other prognostic factors for survival in melanoma. Remember, the most important one is the breakthrough sickness. Then others, we have ulceration. If someone has ulceration, ulceration is associated with poor prognosis, and those can be assessed using the TNM criteria. Then mitotic rate. If someone has more than 1 mitosis per millimeter squared or higher mitotic rate, poor prognosis. Age, it is worse prognosis with older age. And then sex. Men have a poorer prognosis compared to women. And anatomical side, if the lesion is located on the trunk, head, and neck, poor prognosis, as opposed to one that is located on the upper areas where you can just amputate. Then the number of lymph nodes involved, if you remove one node or 2 to 3, 4 to 4, the more the lymph nodes, the worse the prognosis. And then the regional node burden is also associated with poorer prognosis. The more metastases that you're able to identify in the regional lymph nodes, the worse the prognosis. And then the site of the distant metastasis. If the distant metastases have gone to subcutaneous tissue, they have gone maybe to, if it is non-visceral, you have a poor prognosis. So if it is if it is visceral, you have a poor prognosis. So for example, if the meds have gone to the brain, you're going to die earlier than someone who has metastasis going to the skin, to the rest of the skin. So when it comes to management is classified depending on the stage. So 1 and 2, usually you have to do surgery, excise the lesions, and then you have to do a very big margin. So if it is less than 1 millimeter, you do a 1 centimeter margin. If it is 4 millimeter depth, you do a 2 centimeter margin. But then after doing the excision, you have to mark the edges, check for histology with marked out edges, and then see if there is any residue cells that have been left. Then in these cases, usually have a 4% recurrence rate, and also is determined by the person who has operated as well. Then when it comes to stage 3, in this case, you can remove do lymph node dissection, you remove the sentinel lymph nodes or even the regional lymph nodes that are affected, but then with them you have to do what? You have to also eliminate the surrounding tissues because the cells can be infiltrating there as well. Then you can also do a complete lymph node dissection. You remove for example, if the lesion is on the arm here, after removing the lesion, you do complete lymph node dissection. Remove the lymph nodes here, then also the ones of the activity. And then you try to take them for histology and then see if you have left anything. Then other adjuvant therapy that have been used include things like interferon alpha, other things like ipilimumab, which is immunotherapy, a little bit not yet available, but it is one of the options that you can use. So when it comes to a distant metastasis, here you already have a very poor survival rate, 5 years, less than 10%. Sometimes they only survive for about 9 months. So here you're just doing palliation, and you can do things like surgery to debulk tumors. You can do radiation therapy to just give them a few more months, and then you can do other things like targeted therapies, like the BRAF and the MEK inhibitors, and then you can do checkpoint inhibitors as well. So when it comes to systemic therapies, we can use BRAF inhibitors, though not yet available in our setting, or we can use MEK inhibitors or even KIT inhibitors. And these are these are the proteins that are usually mutated in these melanomas. So if you are able to get imatinib, you can use it in case of advanced melanoma. Then immunotherapy, you can do checkpoint inhibitors, nivolumab, we can use it, but not yet available in our setting. And you can as well do other treatments like high-dose interleukin-2 has been tried out, but toxicity usually limits its use. You can also do other adjuvant therapies. You can do chemotherapy with other drugs like the carbazine, commonly used, and it usually has a response in about 10-15%, but all the same, that type of melanoma becomes very hard to manage. And this table summarizes the drugs that have been approved to use in treatment of melanoma. When you go to the biologics, you have BRAF inhibitors, you have MEK inhibitors, then you can have anti-CTLA or antibody inhibitors, and then you can have anti-DL1, and then as well as either antibodies or even antigens. So you can use this if they are available in your setting, but for us, we are still not yet there. So other drugs that can be used, the chemotherapeutic drugs, this is the list: interferon, interleukin-2, focamostin, which is in that class of increased and the rest. And all these can also be tried out in advanced disease. So thank you very much. I know this has been a long one for melanoma, but I hope you learned something. God bless you. See you in the next video.